And hopefully when we're doing the schedule, he's here so he can give us more feedback. And Mr. Jafari can help share that information with Dr. Mushiro and Madam Zura, because we do need all of them to be able to hear what we're discussing today, because that's just the middle part of the logistic and training to make sure it can be effective when we get there. And so welcome to the 7th QHSC training and logistic meeting. So we have been discussing and trying to make sure we get all the things that need to be planned ahead to prepare for the medical mission training, face-to-face training at Muhimbili, Buguruni, and Mwananyamala hospitals. So we want to make sure we offer effective training that the healthcare workers over there, our colleagues, will be able to use that knowledge and then improve patient care. So we were tasked to be able to provide training that can at least address the needs for newborn indicators. That means usually if the babies are born with certain things and or certain practice, and then we have neonatal mortality. So what are the things that we can do to improve or decrease that number? So there's a lot of stuff that when we come to do face-to-face training, it's going to address that issue. Part of it is for the neonates and the other part is for the maternal part. I'm going to share the tentative schedule. It's not done yet, but just tentative schedule for what we are looking forward for that September, especially the first week of our visit there in Tanzania. And then I'm going to review some of the things that we have been doing so far to get ready for those 2 weeks. So again, welcome and good morning and good afternoon for everybody who is here. I know I have Miss Maricela here, Miss Bree, Lady Victoria here. That's Hunter. Yeah. Miss Hunter is here, Mr. Jafari and Mr. Siakabe. And I know we did invite other leaders from all the 3 hospitals. So I'm hoping either they will momentarily join or they'll be able to see this video and provide feedback, hopefully before the next meeting, because we're running out of time. And it's exactly 2 months to get there. So 8 weeks. I don't count the first week of September because it's going to be on by that time. Everybody is packing the suitcase and stuff, weighing stuff and reweighing stuff because it's going to be crazy. But anyway, so welcome. And I'm going to go through the agenda and then let me know if you have any questions. You can stop me anytime. We don't need to wait until the end because sometimes you forget what you wanted to ask. So if there's something that I'm going to address later, I'm going to say I will address it later, but I just want you to address as we go. So if there's something I forget, then I have to add it as soon as I can. So thank you again. And let me share my screen. If I can find my, there we go. Okay. So the agenda for today, it does look skinny, but it's not. So we are going to review so far what we've been training, and then we're going to discuss the takeaway from last meeting, which was June 24th. And then we have the current agenda, which is the tentative training schedule and a lot more. And then at the towards the end, there's open discussion, which there are a couple of suggestions that we want to share today and start thinking ahead before we get there. Okay, so from the previous training, so far the QHSC global training includes, we did May 19th, we did the neonatal part, and then we had 20 attendees, and then we did another training May 26th, neonatal temperature glucose, and we had 40 attendees, and we did third training, which was June 9th, about ventilation, we had 35 plus, and then we did the last one yesterday, June 30th. That was on fetal monitoring, and we have Dr. Emma Okurumgeri, Professor Michelle Brown, and our very own Mr. Jafari Utavi. And we had almost like 31 people who I can account for, because some of the time people log in with a phone, so, and then they were in and out, so it's hard for me to keep ties and see who is there or not. We're gonna try to improve that so we can capture the number of the people who are attending, so we can see at the end, like how, for the 3 months, how many people did we touch to teach. And so it's going to go up to 40 because Buguruni had, I believe, 7 in the group. So they were using only one central area. So you can add there. So it might be close to 40 or maybe like 41 or 2, but it's great. So to have that big number, and I know it's the middle of the day for Tanzania. So sometimes it's hard to have a lot of people during the busy time, but that is the time that was suggested and recommended from our colleagues. That Statistic less busy compared to the morning and the middle of the day, and the end of the day, most people wants to go home. So the future training includes July 14th. That's the fetal monitoring session number 2. We did session number 1 yesterday, and then we're going to have session number 2 where we're going to get the nurses and doctors from those 3 hospitals and have our very own Mr. Jafari share again the case study 3 and 4, and then we dissect and break it down and just to make sure for each hospital, how could we have taken care of that patient or that mom or that baby to make sure we are trying to establish best practice and using evidence-based practice to improve patient care. So that will be the second part on July 14th. Another session is scheduled for the July 21st. That's diabetic screening. Dr. Gideon Mlawa from UK, Ms. Nancy Littner, and Mr. Jafari, of course, he's going to be probably our constant participant. And then Ms. Nema Minja is going to be from Buguruni, so they're going to be participating in that part. We're still working on those more details will come. And then that also is going to include the screening diabetic pregnant protocol. So we're going to review some of the protocols that they're using right now in Tanzania for pregnant women. And then Dr. Gideon Mlawa and Ms. Nancy Littner are going to share what the best practice is done and then compare to what is done in Tanzania and what things can we supplement for what they're doing right now. And then the next one is still on the works, July 28th, that will be postpartum hemorrhage, identifying the risk factor and drills to be able to learn the team that is supposed to support if the mom is being identified as with postpartum hemorrhage. So what do we need to do? You know, what the role of the nurse, what the role of the doctor, what the role of the anesthesia. So all those is going to be included in there, and we're still working on it. So the presenter might change if we get more people who are involved, because there's some people I'm still talking to them right now. So the presenter for postpartum hemorrhage might change. But as of now, we have our group there. Other topics is left to be done is the obstetric emergencies, anesthesia and transportation. That's Dr. Gwen Rando, Mr. Bashir Mari from Buguruni, and Dr. Moses Mulungu for Muhimbili. We're still working on it. As soon as we know the date, we update you. More likely it's going to be in August, because July we already cover all the dates. Okay. And then also we do have the neonatal hypoglycemic protocols. That's for the babies. It's going to be a date in August. I'm waiting for Dr. Msambichaka and Dr. Akida from Buguruni, Mwananyamala, I'm sorry, to give me the actual date. So there will be 2 more sessions for the neonatal training for that month of August, and then we might have 1 for the anesthesia for that month of August. So there's more training. I mean, we could have more topics, but you know, we don't have much time because, as I said, it's exactly 2 months left now. It's like almost running to the finish line. So more likely we're going to continue after we come back from the medical mission. There'll be more training, like monthly training. Then those that we put in the schedule, so everybody will know like exactly which month is what topic. So it's going to be a little bit more organized. People can choose which days they come in, and we try to share as much as we can. So, and thank you for everybody who have been coming to those training, because we do need people to come in and ask those questions so we can tailor our training to what you guys need versus just sharing whatever we think we practice here. Okay, so takeaways from last meeting, we knew the number of the people who will be there. So Buguruni is going to give us 35, Mwananyamala is going to give us 95, Mr. Jafari did communicate with Dr. Mushiro, and then right now we have from Muhimbili is 220. You're going to see more details on the next page there. And then we're still waiting for Mr. Jafari. I think he was working on the protocol of receiving patients. We're still working on it. As soon as we get that, we're going to update. They do have what they do when they receive a patient from those hospitals. So we want to make sure whatever they are doing now, we can match for when we are training Mwananyamala and Buguruni for what the patient needs to be prepared for before they arrive to Muhimbili. And then we do have, we're still waiting for the protocol from Bugurud. I know they send the ones that they're using at the regional, but it says more work to be discussed there. So as soon as we get that, we're going to update you. And then we did have last time, Mr. Raymond shared his best practice of what they're doing during transport. He's an EMT basic, so he transports the patient from one location to the other, either from residency to the hospital or from one hospital to another. So he did share his experience. And then so you can review that video, and then he gave us like almost like 5-8 minutes of what exactly he does as soon as he get the patient. So, and then we're gonna share the protocol that he uses with Tanzania. So I know Mr. Jafari and somebody else was asking for it. So I do have that protocol, and I'm gonna share as soon as we finish this meeting. Now the schedule. We are still, as I said, whatever I'm going to discuss today, it's going to be just an overview. It's going to change just because of the moving things. And I will tell you what exactly is going to probably require to be added in there for us to have a full complete schedule. So it's going to be updating every meeting until we get there. But at least we have just a little skeleton of what exactly should be happening when we get there, and then what is needed. So I will give you a little rundown for after that. Okay, so we do have the newborn outcome indicators statistic for Mr. Mbinda, and thank you very much for giving those data. So as of now, we know neonatal mortality, that's the rate, is 43. So out of 1,000 babies, 43 died, and then we need to figure out why and from what, and then so we can try to modify if there's any risk factor that can be modified to improve those numbers. We need to do that, and that's why we're doing all those help baby breathe training and hypoglycemic, thermoregulation, and newborn care. So all those things are included in there. So we're going to work on try to dissect and try to figure it out to what we can contribute for that. For maternal mortality, of course, the biggest one we have is a postpartum hemorrhage, which we are trying to address by providing training for that postpartum hemorrhage and diabetic screening, because we know that's a big risk factor. Mom is diabetic, we don't screen her glucose level, baby becomes too big, the uterus expanded too much, and the baby comes out, and then mom's uterus does not contract, then mom loses more than necessary, and then they might end up dying because of that. So to me, that 432 out of 1,000 moms, that's too much. That's close to 50%. That means it's a scary number. We need to lower that. And I believe some of the deaths are preventable. So meaning like we can do something if we identify early on, we can address it and try to minimize that number because that number is too big. The low birth weight, and of course the same thing also when we are screening these moms during pregnancy, we need to identify if they have any issues, medical condition that to reduce the placenta perfusion. So baby does not get enough nutrients and the baby end up to being so small. So either mom does not know what the nutrition things they need to eat during pregnancy, or whatever they're eating is not helpful for the baby, or if they don't have anything to eat, do we have any resources or support in the community to try and address that part? So there's a lot of stuff that we need to do. And then of course, the baby dying before they reach to 5 years old. So some of them might be under malnutrition, the baby's a failure to thrive, baby are not getting enough, and the nutrition wise and stuff. So some people will be breastfeeding, is it enough? For the bottle feeding, are they bottle feeding the baby the right things? So all those things we need to add, infection, you know, hand washing and all those stuff. So those are things that we need to dissect and try to address one at a time. As I said, this, we're not going to solve this concern in a month, in a year, in 5 years, probably even in 10 years. However, we need to start rolling those numbers. So if we can start chipping away with those numbers and try to improve year after year, then eventually we're going to probably improve. And then some of them, it doesn't matter what we do, the babies or the mom are going to die. However, if we can prevent it, we need to do that. So you need a definition, an actual definition of neonatal mortality for Tanzania to get at the 43 number. So I'm gonna wait for Mr. Mbinda to provide that part currently, so we can have a working definition, I'm sorry. So for us to say, okay, when you're working with the neonatal mortality rate was 43 out of 1,000, we need to be able to say, this is the criteria that that baby met. So if the baby dies but does not meet that criteria, they might not be able to be added to that percentage, to make sure we are adding only the babies who qualify or meet those criteria. And then we have to address and have to explain why do we have that big number. So there's a lot of stuff that is going to go continue behind the scene. because this is almost like a research base. So we need to be able to address and have a working diagnosis. Means like whatever data we are collecting and what we are teaching, it's explaining to give us the better outcome for these babies. Okay, so now we come back to the number of the staffing people. So we do have, as of now, Muimbili is going to give us 220. There's 200 nurses, which included the midwives in there. And then we have 20 medical doctors, and that includes the residents. So on that list, I did not see the anesthesia. So when we do help baby breathe, and sometimes the baby require more acute care, that means they might need intubation, or, you know, like, so we do need to get anesthesia. Maybe they might get a different training, because they do intubate now if it's needed, or the mom is delivered in a C-section. So we need to do that. So I know Dr. Mulungu, who is in charge or is one of the anesthesiologists in Muhimbili, we're going to continue working with him and see if there's anesthesia people will be able to come to the training. So if we get them, then that number is going to increase. But as of now, we have 220. On Anyamala, we have 95, but although when they send me the list, he has 99, unless maybe my math is wrong. Marisa is going to help me to add them up. But as of far, we have 62 nurses, which including the midwives. We have anesthetists, 11 of them. We have medical doctors, 16 of them, and we have specialist doctors who are 10. So if you add them up, I got 99, but who knows what I'm going to do to add these people. And then, so Buguruni, I still need, I know that they told us they're going to give us only 35, so we need to know the doctors and nurses. The reason I need to know these different levels, because when we assign or we're doing training, the doctors need to do what the doctor needs to do, and then the nurses needs to do what the nurses need to do. For on that situation, we really need an actual medical doctors performing or ordering, providing orders or giving a diagnosis, why the nurse needs to be able to execute that diagnosis and do what the nurses do, the intervention. So yes, sometimes we do nurses pretend to be doctors, but that usually does not give us the reality of the actual situation. So if we can get the doctors involved there, it will be very, very helpful, because we need to have everybody takes their own role that they're going to be doing. So then it becomes familiar on the situation when the event happens, because it's going to be a stressful event. When you see the baby is not breathing, when you see mom is bleeding, almost going to die in front of you, you're start going to panic, you're going to get stressed out. So if you did not practice that role, and if you did not, you've never worked with the doctors in that situation, how are you going to know what they're going to say at that time? So that's what we want actual doctors. They need to assume that role. If the role requires the anesthesiologist or nurse anesthetist, we need that person actually with that title to have that role. The same thing for baby, the same thing for mom. So we're going to continue that conversation. And that's why I said that number may improve to have more people than what we currently have. Okay, so that's part of that. So for today's agenda, I know everybody wanted to know about the training. As of now, the training is going to be done in one place, the first week, the first 4 days. So that will be the September 13th to 16th. So it's going to be Tuesday to Friday. Right now we have, I think, 396 or something. I just put 400 just because it's easier for math to divide on this different session. So we're going to have 400 healthcare workers, doctors, nurses, and midwives. On the part of the doctors, are the anesthesiologists and all this stuff. And then, so because it's 4 days, we're going to divide those 400 to 4 days, which we get 100 per day. And then, so it'd be like 4 times 100. So I'm putting this in the actual logistic and scheduling purposes. So morning sessions is going to be from 8 o'clock to 12 o'clock. And then the afternoon session is going to be from 1 o'clock to 5 o'clock. This is tentative. So for example, if our colleagues in Tanzania said, oh, it's going to be better to start at 7 o'clock to 11, and then maybe 12 to 4, that is fine with me. We can start at 7 o'clock. All the healthcare workers, they know, sometimes you start to work at 6:45. That is the normal for us. So if it works for people in Tanzania to have 7 o'clock to 11 versus 8 o'clock to 12, we're going to change it. I just want that morning spot is 4 hours, and then afternoon spot is 4 hours. Okay, so in that morning times, we have 2 sessions. So 2 sessions, we have like help baby breathe, it will be from 8 to 10, the first 2 hours, and then postpartum hemorrhage demonstration and mock drills, it will be 10 to 12. I put those 2 hours, not necessarily that the training is going to take 2 hours. It might be an hour and a half, maybe an hour and 40 minutes. And then we have 10 minutes break in between to switch the stuff and because set up for the next stations and all the stuff. But I put 2 hours exactly so it will be easier for planning and logistic purposes. But the first 4 hours, so we can capture those people who are there to make sure they are able to stay there for 4 hours. This is also helping with the scheduling purposes. So when you schedule somebody for training from 8 to 12, then you say maybe 12:01, he or she's going back to the unit. So we want to make sure 5 minutes or whatever before 12, the people are going to where they're supposed to go. Because remember, they'll be working close by, especially from Muhimbili people, or the people from Mwananyamala or Buguruni, they'll be coming to Muhimbili, do the training and then go back either to the hospital or go home. I don't know what the logistic part on their side, but that's just for planning purposes. And then the afternoon session is going to be exactly the same thing that we did in the morning, but we're doing with a different group. So if we're thinking of 100 people in a day, so that means 50 people in the morning, 50 people in the afternoon. However, sometimes morning might be better for scheduling versus afternoon. So you might have maybe 40 people in the morning and then 60 people in the afternoon, or 60 people in the morning and 40 people in the afternoon. All in all, wherever we can, we do 100 people in a day. That's it. And then if it's more than 100, then we can pad it. I mean, the schedule can accommodate even 120, you see in a few minutes. So, but that's just for logistic purposes. Okay, so those are first morning and afternoon session for 4 days. So for the Health Baby Breathe, those 2 hours in the morning, 2 hours in the afternoon, we need 10 stations. So with 10 stations, with each needs 6 healthcare workers. So those 10 stations, you need 10 facilitators, the person who is going to be running the training or the evaluation or whatever, with 6 people, healthcare workers. So within those healthcare workers, we need 1 or 2 doctors, and we need 4 or 5 nurse midwives, because again, there's the role of the doctor who needs to do in that area, and then we have the role of the nurses. So each station has to have the doctors and has to have the nurses. And then the same thing for example, for the postpartum hemorrhage, we can have 5 section or 10. So it depends on the amount of the people. Advantage of doing the postpartum hemorrhage the way we usually do the training is you can have the active group and the observer group. Means the active group is like you can have 6 to 8 people doing the actual activity, and the other ones are evaluating to see what they missed, what they. So that usually is observing, and then they switch. And then you go and start performing also, because you've already learned from the previous group, whatever they did, go and perform yourself. The reason you do that, because it increases your understanding, because you can see, so you'll be almost doing that training twice within that time. And then it always makes a little bit more interactive, because you can observe and then go and perform, because you've already observed what either they missed or they omitted, and then you can add what you need. But also that's logistic purposes. It depends on how many people we're going to get for that time, and that it's going to be. So if we can get only a small number of people and we break them in 6 each group, that's fine. But in the postpartum hemorrhage, we do need the following people. We need the lead person, has to be a doctor, because they need to be ordering stuff around. And then we have an active doctor who, like for his postpartum hemorrhage, there's a placenta tissues left behind. They need to be actively put in there. I know Tanzania, they might have allowed midwife to do that. So whatever the role allow you, then we're going to discuss in details with each hospital to make sure what is allowed and how much midwife can do, how much the nurse can do, and how much the doctors can do. But we do need the doctor there for all the session and all the section, because we want to make sure the doctor is also is the one who is giving those orders. And then usually we have a nurse, a primary nurse who is the nurse's patient, and then we always have the second nurse, just because for nurses, you know, if I'm worried about something, worrying about the vitals, somebody's starting an IV, somebody's doing something else, drain the bladder. So you have to have people who are skillful enough to do those roles as it happens. So that's why we have primary nurse and second nurse. Logistic-wise, we're going to discuss it with Tanzania to see how many people are allowed in this event. So that it may change. We need a scribe. This is the person who catch every event happen and put the time to it. So you know, if we did resuscitate this mom, how long did we spend and how much did we spend doing whatever? When did we start an IV? Could we have started earlier than whatever we started? Which medication did we give? Did we give the medication in at the right intervals? Did we delay? Why did we delay? Did we miss the medication where they were supposed to be? So all those logistic part is because there's a specific person or the charginess. The person who is the charginess usually is the one who decide, seeing things how they're happening. Oh, we need to order blood. We need to call the blood from the blood bank. Did you send somebody else? So somebody has to be overseeing this part to make sure things are happening. Because if I'm busy massaging the fundus, somebody's bleeding and we're trying to evacuate all these clots, I am not going to be thinking, okay, did you give this medication? What time did you do that medication? If the patient is breathing, because I'm like here on the perineum, I am not going to be able to see what the patient is on the face. Somebody needs to be evaluate the situation. That's why we need the number of the people. So 6 to 8 people more likely. Here in the United States, we do have a person we call OB-Tech, obstetric technician. This is the person who is always help be like a second person in the operating room. So this is the person that if we say we need to go back to the the operating room to do either evacuation or hysterectomy or whatever it is, this person is the one who's going to be going to the OR and open the stuff rate. We're going to discuss with Tanzania colleagues and see what do they have? Do they have that person who is responsible for that part? But that person needs to be there to see, okay, we are trying to evacuate and we can't solve, and then we're going to lose this mom, we need to run. That person needs to run and go and get the OR or theater ready to go while we're getting the patient to the operating room or the theater. So all those things, I mean, requires a little bit more planning. And as I said, for the next month or so, we're going to have those stuff. By the time we get to the end of August, all these things, we have the names and people who needs to be spat. So it'll be a little bit more organized and more details. The next thing, so when we're doing any training, we do have to have registration. So this is the part which people are non-healthcare workers who are going to be included in that presence there. They're going to help with the registration. So when everybody comes in, we need to know who is coming, when they're coming, their title, their credentials, because we are going to give them the certificate of attendance. We need to get their names and their credentials. So if it's a nurse, if it's an anesthetic, if it's a doctor or whatever, we need to give them credit that they were there. And then pre and post survey questions. This is usually like 2, 3, 4 questions before they do the training and then at the end of the training. We use this for improvement purposes. We want to know, what did we miss? What could we have done better to make sure the next training is improving? And usually it'll be like an ongoing improvement, because we want to know for the first session, what did we do? Okay, did we miss something else? Maybe we could have added something else. So the second session is going to be better because we want to make sure we include that part. We don't want to wait until the end of the training and find out, oops, maybe we could have added a certain thing that could have improved the training. So it's an ongoing, and that's why we need those non-healthcare workers to be able to be present when you're doing all those training. And then of course we need 100% attendance. So anybody who is scheduled to come should be there. So then we can address them instead of like having only 4 people versus 6. So then we have to ask people to do 2 roles, which they should not, because in reality, the next person who was supposed to be there was not there. So we want to make sure we get as much as we can. And that's why we're going to try to get everybody identify in the list. And of course, for scheduling purposes, we're going to know exactly the name of the people who are going to be there on Tuesday morning, Tuesday afternoon, Wednesday morning, Wednesday afternoon. So at least that will help us with the logistics and giving them the certificate of attendance. Okay, so how do you know who is going to be teaching what? So we do need the facilitators. So QHSC have 30 global volunteers, but they're going to be scheduled according to the activities. So some of them will be going to school, some of them will come training, especially the first week. So we do need confirmation to know how many national facilitators from Tanzania are going to be able to join us. Currently, I know we have the number is 11. I'm not sure if all 11 will be able to come, which will be an excellent thing because it's going to alleviate some of the stress for the volunteer, meaning like the number of the people. So we want to make sure we can have every section, every place with adequate number of people. So if we get those 11 national facilitators, and I think Mr. Jafar is one of them. So we're going to probably tag team him somewhere else. So, but if we can get as many as we can, that would be great. And once we know that number, that will help us to finalize who is going to teach which session, who's going to be in which section to be able to address, and do they have enough equipment to teach. So for Help Baby Breathe, for example, for facilitators, for QHSC has 10 already who are specialized or trained for specifically for Help Baby Breathe. So we do need also the national facilitators to try and address those other sections. But as I said, we're going to continue planning this part, and then towards the end of August, we have exactly who is where and who does what. So that'll be good. Okay, so with all planning, we need to know if we have enough equipment. So we are working on a lot of treatment, equipment, and then we are ordering stuff with a Lido Global website, which we're getting a little bit confusion, and because the price we see online is not the price that they're quoting us to buy those equipment. So I was going to ask you, Mr. Mbina and Mr. Saturini, to help us with that, because the global the Lido Global website, it says Tanzania qualified to be one of the group that we can have a discount when you're buying these equipments. However, when we ask the Tanzanian vendors, they are giving us 3 times the price of what the Lido is offering. So that's the confusion there. And we cannot afford those 3 times prices of what they're telling us. So that is going to be an ongoing discussion on the side with Mr. Mbinda and Mr. Saturini. If they can help us with that process, that would be great. Or if Mr. Jafar, you have any suggestion for that, that would be great. Current equipment, so now we have, from MUHAS, we have 5 sets of neonatally. And then TAMA, they have 5, and Mwimbi, I think, have 2 of them for Help Baby Breathe. They have 1 baby natally for skin to skin, which we can use that for teaching the thermoregulation stuff. Mwimbi also has 1 Mama U for postpartum hemorrhage. Mwananyamala has 5 neonatals for Help Baby Breathe. We're going to need to find out, do they have like a whole set or instructor set or just a regular kit? We're going to find out and figuring out if we need to add more stuff like that. And then, so we need to find out if Mwananyamala have the Mama U for postpartum hemorrhage, because remember, we're going to have probably like 5 to 10 section of the postpartum hemorrhage, so we can have every single person who's coming for training, they need to touch those equipments to be able to practice. We need to find out how much Buguruni has, either the neonatally and the Mama U. We're gonna get the answer from, I think, Dr. Flowoko and Dr. Dina Komakoma. We're gonna get that information so we can update our supply list. So we are working as a group of volunteers. We are working on getting some equipment. Some people who are teaching, they want to bring their own equipment, which is fine. We're going to update with you once we tally and see all the stuff. Something that held us back because we wanted to buy stuff. And so once we buy, then we know for sure every single person who is coming from US is going to have, I mean, so not every single facilitator who is going to be doing the training, they will have their own equipment. But we have the little slowdown now with the vendors in Tanzania, but we're going to keep working on it to try and see how we can get those supplies to Tanzania. And if Tanzania can offer more supplies, that would be even better, so we can accommodate those 400 in 4 days. My other question is if Mr. Jafar, you can help me, or Madam Zura can help us for the audio visual projectors and stuff. Those things are needed for training. What exactly, how much do you have right now? Can they accommodate 100 people in 1 day? So if we have session and we have small, like little video, a 1 or 2 minute video demonstration of what exactly we want to evaluate them, can we show that, or it has to be in a big screen, big auditorium for everybody to see it once? So that is going to help us with logistic and planning. How do we plan those small sessions, or should we start with a bigger group and then go to individual session? So, but it also depends on what the audio and visual supports we have from Muhimbili. So once I'm gonna let Mr. Jafar answer that now, and then we're gonna continue at the end. So this last thing is that since we're gonna be working there almost for 10 hours, 12 hours, we're just gonna wanna find out the logistic of how we can get food for the people who try to get them to give us the information about, I mean, how much equipment do you have now? And then if we need to use that equipment for small groups, how many sessions they can support like that. And then the last one, as I said, it was just food and water and stuff, because when you're training and all the stuff, that is And of course, the weather in Dar es Salaam, it's going to be sweating and stuff. So we do need some water and food. We don't want to like leave and go somewhere else because it's going to lose the time that we have. That 1 hour is not that much, because remember, when we're finishing one session, cleaning up on the equipment and stuff, because remember, people will be touching it. We have to be able to sanitize and stuff already for the next session in the afternoon. So we're not going to have much time to start going somewhere else to eat. And if there's an accommodation that we can get right there. So we're going to figure it out, that part, and we're going to update as we go. I think those are the only what I have. Mr. Jafai, are you back?
Yes, I'm back.
Okay, so one of the questions that I don't know how much you heard when I was talking about, but one of the questions we were asking right now, when you do the training, let me come out. I feel like I'm talking to myself. When you do the training, yes. Yeah, when we do the training right now, how many audio visual projector computers do you have? And how big is the room that we'll be doing the training? Do you know?
So far for Mwimbili, from Mwimbili, the venue that we are planning to do it, so it's well equipped for the projector. It's there, and okay. Even audiovisual.
Okay.
For audio, we have the PA system there.
Okay.
And a lot of microphone as well.
Okay.
So everything that will be discussed and to be audible to everyone. So okay. For that venue, that's fine. It's work. It will work for our purpose, and it's a big one, so it can accommodate like the number that we have been suggested here.
Yeah.
So as far as we are still planning for it, and we can even try to see on how all these group can be in that room, or maybe we can have another room which is in the same building.
Okay. Yeah, because so once when we're doing the HPB, I mean, you have done the training. Yeah, so we want to have those small groups, like up to 6 people in one group, so they can do the demonstration and stuff. So we want to be able to spread up around. So if we have the morning session at 60 people, so it means you have 10 sections. So to make sure, I mean, they go practice and practice. Yeah. No, yeah, usually they practice the first time, and then you have to give them correct placement and stuff and practice, so they have to do the second time. So that's why we don't want to have like a fewer session and then move people along without practicing enough. So yeah, if the room is big enough to accommodate that would be great. As I said, the more we give more details, I think it will help with you guys finding the room or extra room that if it's needed to accommodate those trainings. So that would be great. Yes.
Of course.
Yes. So quick question. So Muhas and Tamas and then Muhimbili, those are 2 different areas. I get confused.
Yes.
Okay. So
yeah, we have Muhimbili Hospital. It's separate from Muhas, and Tama, it's an independent association of midwifery.
Okay, so because when I was looking at it, it says Muha says 5 sets, and then Muhimbili have 2, and then Tamas have 5. I just want to make sure I didn't write, repeat the same number. So as of now, I mean, I can see quickly we have 12, but we still work on, because we want to make sure, they say in each session, if we can get 2 in each session, when we do the demonstration, at least more people can be practicing. That would be great. With the baby breathe. And do you have, how many Mama you do you have for postpartum hemorrhage?
For you, sorry, Mama Natari,
yeah,
we have more than 5 from Tama, and I'm not so sure about Muas, but in Mwimbili we have 2 of them.
Okay.
Yes.
Yeah.
But so, I think if I get back in town, I'll be able to go to Tama's office, then we'll see how many mama natari are working properly, because the issue is not the number of mama natari. We'll have to make sure that they are all working properly and the other supportive equipment for mama natari are supposed to be there. You know, the issue is when you have the training somewhere and someone took a mama natali, can go in training without taking good care of it. So when they return it back, you might find there is a missing equipment as well. So that's the challenge. So I have to go and check how many, or I have to speak with Sister Lucy. To see how many mama natari is working and see everything is complete.
No, that is, you stole my word, but that's what I was asking. I'm like, are they working? But yeah, so if you can give me update for once you speak to Sister Lucy, that would be great. And then the number of how many you have, because that's also is going to help me to plan how many sections we have. And then is that the same picture you sent me, or was just like the bottom part, not the whole Mama Lucy, or is just the Mama Natalie?
Sorry.
Is the Mama Natalie the whole female? Oh, it's just
yeah, it's a whole female, as an abdomen as well, and the uterus is there, even the placenta is there as well.
Okay, so then that's good. So if you can also send me a picture, so just in case if we need to find one or whatever, we can see if we can bring one with us, or if we can't find anything, so we can use the one that you guys have. And I need to know how many they're working, because that will help. We don't want to get there and say, okay, we have 10 section, and then you find only we have 3 to work. That's gonna delay the training. So that would be good if you can give me an update for that. That would be perfect.
Okay.
Okay. No, thank you. Anybody has any questions or things that you need to know from Mr. Jafari here for what I've just discussed? I know there was a lot of stuff, but I was just trying to break it down so you can have that visual, how detailed we need to get down to that list.
Sorry, I think I have a question.
Yes.
On the modality that we are going to use on training.
Yes.
I think it might be changed, because we will base more on our skills for demonstration and drill as well, especially for the PPH and HPV.
Yeah.
So actually we had a different modality of teaching. So I think before, maybe 1 or 2 weeks before, we need to have a session for all facilitators, at least to just reminding each other on the modality that we are going to use. Because when you take me, I have teaching skills for HPV, and you take a Lucy, have our teaching skills of HPV, we speak the same language, because we're just using that modality that we have been taught before. So as in the modality, if it's change and we are going to use those material that we are always using on teaching in maybe HPV, and we change the modality, so we have to discuss that and everyone be aware on that. So I think if we have a meeting or a session 1 or 2 weeks before the actual session of that would be great.
No, I agree with you. Meeting with all the facilitators will be great. In fact, we can have a meeting probably end of July. So if there's any update or something that we need to revise, then it'll be better. And then end of August, we can have the second one. So by then we can be having the same I mean, we can come from the same background to be able to go and do the training. So for the HBB, we're using your content. We're using, from the website, we're using all the content that you guys are using. We're using those, that's why we're looking for the baby. Not only we're using your baby. We don't, here we use the, like the pre-med, whatever, they have a little bit different stuff because we have to do intubation, you have to do the cannulation of the umbilicus, we have to do the medication and stuff. So for us, the neonatal resuscitation is kind of a little bit different compared to the HBB. The HBB is like the one that you take all the technical stuff and then you focus on the ventilation of the baby. So when they're doing the HBB right now, the Help Baby Breathe, we are using your content. So from that part, definitely. So let's go to postpartum now. So for postpartum, I think for what you have sent me and what Ms. Neema sent me, and that's what we're going to discuss when we're doing the training for postpartum hemorrhage. We're going to use your content to be able to discuss, and I can't use what we use here because we use other stuff, and we have other equipment we use that on the when you call the postpartum hemorrhage event. We have extended things that we do, but I know in Tanzania you don't do that. So the HBB part definitely is based on the what you guys do now. So when they're teaching, they're going to use what you can't use. And that's why we keep asking, okay, what do you guys have? I want to see that picture, because when we come to teach, we want to use what you have to be able to teach. So when we leave, you guys can continue teaching exactly what is that. So I agree with you, then we do need all the facilitators we need to do. And that's why I wanted to know how many facilitators we are available. So if we have enough, it'd be nice to have one from Tanzania and a global volunteer together. So when for example, if I'm teaching and I'm saying something that you guys don't do, that you can say, no, here we do A, B, C, D. If there's something that I said and it's not practiced in Tanzania, we want to make sure it matches and fits you guys. So that's a good point to make sure we get, we talk first of all the facilitators, and then we have the same understanding of what we are teaching. Yeah. So that's a good idea. So I think we can have a meeting at the end of the July, because by then at least we have already played around how many people and we can have, and then we can see. But if I know ahead of time how many facilitators I have, so then it will help me logistically to pair them with people from here. And then so when we are doing the first meeting, at least we can say, okay, so Hayat is teaching with Jafari in this session A. So Jafari is going to be maybe start the part, and then Hayat is going to finish the second part, or whatever, what content we're going to do in the demonstration part. You're going to be evaluating, or you're going to be doing the demonstration. So, I mean, we have to be able to have those people paired way before that day of training. You don't want to meet the other person who is teaching next day at the day of the training, because you have no idea what you're going to be discussing. That won't be good. Yeah,
of course. And I think I will highlight on the names that are sent to you, okay, because some of them are facilitators. So I will highlight those who are facilitator and light they are capable of what maybe HBB or in HMS as well.
Nice. No, that would be perfect. Yeah, that would be helpful, definitely. And then, as I said, we can meet in end of July and end of August to make sure we are in the same, and then we can have an effective training, definitely.
And I got a question for Mr. Jafari.
Go ahead.
Yes, the training room that you mentioned, does it have hardwired internet? Like, is there a way to connect to the internet using a cable?
Yeah, actually, in the room that we're going to use is also there is a wireless which is provided by the hospital, and we can have the access to use that as well.
Okay, so you have both.
Sorry?
You have both wireless and hardwire or cable?
Yes.
Okay, good.
Yes, it's there.
Yeah, because usually I think the hardwire is more stable than the wire, because if you have too many people.
Yeah, and then for the hospital, for the wireless, is there like a public one, or do you have one that's a little less that has better?
Yeah, better... actually we have a public one that it's not everyone is using, which is free. No, it has a password, so it's for those who have an access to that. And actually, the strength is fine as well.
Okay. Yeah, so if we could get access to that too, especially for training.
Yeah.
Okay.
Yeah, that's very possible. Yeah.
And then it's the training room. Is it an auditorium type room, or is it just like a big classroom with tables and chairs?
Actually, it's a room that we using for teaching and times for several meeting, because it's a big room. Yeah.
Okay.
And then so we should be able to put like if when you were talking about having 10 section of the HBB, so we should be able to put 10 tables around and everybody will have space. Then they're not going to be like too close to, like a confusion, but it's just like you can have your 6 people here and then the next 6 people will be like far away, not interrupting each other. So we have enough space.
Yeah, actually, like I said, when you have the group of maybe 6 in each group, yeah, we can do that without any interference between the groups. But behind that venue, we have another venue, which is the smaller one, which it can accommodate even the 3 groups as well. So if we arrange it area, then we can discuss with them that we can use those both 2 venue for that, and that is very possible if you have, or we have to provide this information area.
Okay, perfect. Guys.
No, I was just gonna say that the conference room sounds pretty good.
Yeah, definitely. It's better to accommodate 100 people and you have more room to teach at the same time. So then you have more time to spend with people versus just rushing them through. So that's good. Yeah. And then so for the postpartum hemorrhage, the mama, yeah, we have to figure out how many they are and how many they're working, because that also drive the session. But I said the advantage of postpartum hemorrhage, kind of different from the HPB, is like you can have those 2 groups watch each other, so you save. We don't have to have an extra mama Natalie or the mama you. So that'll be fine. But if we get more, that's fine. So they get to practice more. That's okay.
Oh, maybe I can share a screen so that you can see the how big is the room.
Okay, I'm gonna give you my power.
Okay.
Share the power.
Thank you.
I like to share power, only for some people.
Yeah, as you can see, the room that I'm talking about is this one.
Okay.
So it's a huge, and those are chairs and tables that, so in between it has a space that we can adjust tables and remove some, so we can see how big it is.
Okay.
Yeah.
Oh, that's good, because I can see, I mean, even the way they have the tables, if you just turn around the chairs on the other side, then we have those sections. Okay.
Yes.
That looks very fancy room. I was like, I'm thinking like auditorium, like you sit on a bench or something, but that looks very nice. Okay.
Can you go back to the picture of the speaker?
This project.
Okay.
Yeah.
No, that was very nice. Yeah. And they have very comfortable chairs.
So, yeah, and speakers is over, just attached on the wall. So that's a podium that we are using, and even the projector is attached on the top of that. Right. Yes. Yeah.
That's Jafari.
Yes.
We didn't show it in the beginning.
Hey, we gotta hire that guy, the speaker guy. We gotta hire.
Okay,
Okay.
that's one. Yeah, this is Mr. Kamana that I told you, Dr. Harriet.
Okay.
I'm working very close with him, and I think we have him later on.
Okay, yeah. So we put him to work.
Yeah.
We know
Okay.
his experience.
Because, yeah,
There you are.
yeah.
No, that's good. That's good. That looks adequate, I think.
Oh, no, that's good. That's good. And then, do you think we need a backup projector, Harriet, or should we just depend on that one?
No, we always have a backup. I mean, always like that. Remember when we went to Dodoma and they tried to give us the projector and they didn't work with our computer because they.
Right.
So we always have to have a backup. But I mean, they're thinking their audio visual there, it looks a little bit more advanced in the sense that, I mean, it's almost like the same thing like what we're using here. We just need to, at least advantage, we're using a wireless, which is better. But I mean, for the hardwire connection also, it's a stable. I like the hardwire connection because I know for sure it's stable compared to the Wi-Fi.
Right.
I mean, I think that'll be good. And then if we can see there's a white wall that you can project content. So it looks, that's good. That's good. Phew.
Give us a visual.
No, that's good. That's good. Thank you for.
And I think you can set up the stations right there on those tables there. I don't know if it's
That's what I'm
10,
saying.
but maybe along the walls, you can have some, if it's not 10.
If you change the chairs from the other side and put the tables together, there'll be another section there.
Okay.
As long as the tables are movable, so which is fine. So let me ask you, because you have done so many training there, what do you see the logistic things that we need to include for us? Maybe we did not attach. What do you think?
Actually, when you mean logistic for participants, or
yeah,
it depends. It depends on what we planned and the way we approach the participant as well.
mm-hmm.
So as for now, we need to think that we're going to provide them education. So we going to impact knowledge to them. So it's maybe if we have just a small amount or what, or just transport reimbursement or what, but I really don't know the budget for that, and that's why I just started on to talk on that, because I really don't know the whole budget the way it is.
Okay, so that one probably we have to discuss on the side, because for people here, I mean, everybody is volunteer, they're paying for their own way, everybody. So it's, and that's why even buying the equipment, people are willing to buy the equipment because they're going to come and use to teach. But then I think the vendor in Tanzania is charging 3 times. We're buying, I think, like 800 and something, and then they're charging 2,700. I'm like, for the same things. And I'm like, no, I mean, it's not like there's money somewhere. Everybody try to do your fundraising there to try and get some.
Or maybe you can just request for exemption from TMDA area. You can just request it from online. Then when you import those equipments, will be exempted from revenue.
Yes, so I think Mr. Satrini,
taxes.
Yeah, Mr. Satrini was going to help us with that. So those are things that we already ship. But this is like you go to the website and they say Tanzania qualifies. So if we are shipping to Tanzania, there was a telling us, okay, it's like $25, and then you're going to be picked up in Tanzania. So we're like, okay, yes, that's good. And then so the vendor in Tanzania is the one give us 3 times the price. I'm like, if it's already in your country, why am I paying like 3 times? I don't understand. So we're still working with them.
You know, it depends on the vendor that you're using. Because actually, I had I ordered the ultrasound from yours as well. I had the project for obstetric ultrasound, and the vendor that we use for importing them, it's at least the charges is not such high, and those ultrasound was not even exempted. So if we request for exemption, then TMDA will provide a certificate for that. I think the costs, the taxes will be low. So we don't expect it to be 3 times or what, because the calculation that they did, they have to take the at least the amount or the cost of that property that you're buying from your country, and when it comes here, it has to at least to pay.
Okay, so do you have the name of that vendor? Maybe we can ask them and see.
Name of the vendor.
Mm.
Let me check. Then I will send you to.
Oh, you can send me after the meeting. That's fine. Yeah. Yeah, because I mean, I think we want to, as I said, I mean, a lot of stuff that we are doing now, it's out of, I mean, the volunteers are contributing or buying stuff on their own, and then they just want to come and do training. So it's not like the money is somewhere else, so we had a grant or anything like that. So we're trying to get the stuff that we need for to come and teach. But so when somebody's asking you to pay 3 times, as if I'm coming to sell it, I'm like, no, in fact, it's gonna come and be delivered even in Muimbili or Mwananyamala. I don't even go to sell anywhere. It's not for business. And that's how they publicize on their website. They're saying, if you're buying and it's for non-profit and you're going to a vulnerable population, then you get the same price. So, okay, we are feeding on those things. Yes, non-profit organization, and then we're going to teach, and it's not like we're going to sell it anywhere else. But still, but anyway, we're going to work on it. And then if you send me the vendor, we're going to ask them and give them things that we wanted to buy and see if they can get in cheaper price, and then we'll figure out from there. Yeah, but yeah, so Mr. Saturini said he was going to talk to the person from he said pharmacy, somebody's in charge of to get exempt. He know the person, and then he said, like, once we have the list, then we can give it to him, and then that person will be able to give us that the exempt, and then we'll be able to. But those are the things that we are shipping from here, like, because. But the website was saying things will be delivered there because that's their vendor on that website. So I don't know, why do they have different prices? I don't know. But I mean, we can work with your vendor and see what they offer, and then continue from there. Yeah.
Okay.
Okay.
Yeah, I think Jafari will come up with a better source.
We hope. We hope. So I think I have one more last thing. Let me see.
And then I got something too towards the end, if possible.
Okay, so the last thing was just we were hoping that although Mr. Jafari already mentioned that part with meeting with all the facilitators, I wanted also to meet with all the stakeholders when we get there on Monday, because we want to be able to meet the people who have been involved in the logistics and planning. We want to be able to talk to them face to face on that Monday, and then when we start Tuesday the training, then we have some understanding who is who, and and continue working with that part. But I do agree with you, Mr. Jafari, that to talk to all the vendors, so all the facilitators who's going to be doing those training, they need to be able to discuss it so we know, and we're going to share the content that we're going to be teaching, which is going to be based on what you guys do. And then you have an input, definitely almost 99% of the input that what is done now and what is going to be applicable now, and then so we can continue with that part, because it doesn't make any sense for us to come and teach something that is not going to work. So we don't want to do that. But yeah, I think we can plan the end of July, and then just tell me which days possible, or we can turn one of these meeting to be meeting on the the facilitators. So it depends. If you want to do that way, that's fine. Okay. Because it can be, let me see, what's the last Thursday of the month? So it'll be Friday, sorry, the 29th. So we can probably tell them ahead of time, if you know the names of the people already on the list, then we can tell them like July 29th. We can use this one of logistic, and then just to have all the presenters and stuff to be on that meeting. At least so we can discuss what it is. Do you think this time is better or 7 in the morning? Oh, no, 7. So yours is going to be 2 in the afternoon. Which one is better for this for that meeting with the national facilitators?
I think maybe when we start from 2 at your time.
So 2 is yours. Ours is going to be 7 in the morning.
Oh, no. I mean 3 for us. At least some of people, maybe they might be out from work.
Okay.
Because when we do at 2 here, most of them will be still at work.
Oh, okay. So if it's 3 over there, so up here it's going to be around 8 in the morning. Okay.
Yeah.
No, so then that's fine. We can just, that meeting on the 29th, then we can move that to be 8 in the morning here. And then 3 over there, yeah. Because we want more people to come in. So then they can provide their feedback. But yeah, so we can start telling people who are teaching from here then to try and get it Friday morning for that day to be able to discuss. And hopefully by then we'll be sharing in the sharing the content, so we can start working on the content to make sure they can provide feedback on that day. Yeah. Yeah. Question, guys.
I was gonna ask if Bree and Maricela and Jafati and Hunter, if they've met Victoria Jones before. I'm not sure if she's available, but she is one of our board members. So I was thinking it'd be a great time for her to introduce herself to the team.
No, I haven't.
I haven't either.
Yeah, I've seen her, but I haven't met her.
Lady V.
Even I.
Good
Good morning, everyone. They call
Morning.
me Lady V, but my name is Victoria Jones. To tell you a little bit about myself, I got into, I'm a burn specialist by profession. I'm currently retired. I got into burn care back in 1998. I know it's kind of foreign for some of you young people on the call. But anyways, I got into burn care in 1998. I wouldn't say by happenstance, but I was burned as a child and never thought in my lifetime that I'd be working with burn victims. So anyways, as I applied for the position, the next day they hired me. I had no clue about what I was going to be doing or encountering. But as time went on, it grew on me, and I began to love what I do, and it just became a part of me. And so I just love the particular aspect of being a nurturer to the victims and to the family and the survivors as well. So with that being said, time went on and I stayed there for 31 years. So my takeaway from that is that now I would like to give back in the sense of being able to help other people. Through this invitation with Dr. Gabone, she invited me to come on the mission trip last year, and it opened my eyes to another whole world of burn victims and burn survivors. So I think with that, I'm trying to see what it is I can do and what it is I can offer at Mhumbili Hospital. And so, right. So with that, Dr. Gabone invited me to be on the board. That was another surprise in and of itself, and I accepted. So I'm hoping that I'm able to give and render whatever it is that's needed for this mission. Thank you.
Thank you very much. Thank you, Mr. Sekabe, for including that part. I was already just too excited to see Lady V around, so and then I forgot that I need to introduce to people. But anyways, she's so modest. Just to add to it, when we went last year for Dodoma, and she was able to take care of this young man, and work with the family, work with the nurses and doctors, and she is worth of knowledge. And she was talking to people then, I'm like, I am a nurse, but I didn't know that much things can be done for a patient who is experiencing burn. So she was great. And then she went to Muhimbili for the whole day. We have to start calling, okay, we need to go, and we are done with our tour. She started working with Dr. Mrema and started talking about the burn victim and stuff. I'm like, wow. So she went to the pediatric unit where they have a lot of kids. It's just heartbreaking. But she's going to do wonders also again this year. And she has so many things already scheduled for these kids. And she's an asset for our organization. And we thank her for dedicating her time and talent to these people who are experiencing burn. And there's a lot of stuff that we need to do. Usually, I mean, as a nurse, you just think, okay, I'm going to fix the wound. I'm going to do a dressing change. Okay, start healing and go home. No, but she goes deeper for what they eat and what they're experiencing and what, I mean, like the contraction, prevent contraction and all the stuff. I mean, she went deep to those things. We do need those people who are passionate like that. So thank you for being part of our family and for taking the time to go and see our fellow Tanzanian over there. So good.
Thank you.
Yeah. Okay, so anything else? That's what all I have for today. So just the takeaway is Mr. Jafar is going to give us some update when he can about the Mama Natalie to see how many they're working, and then if we can get a picture of it, that would be perfect. And then we appreciate for you suggesting that we do need to meet with the facilitator. So we're going to have the meeting on July 29th at 3 Tanzanian time, which will be at 8 o'clock in people in the US. So you should be awake, Maricel. We have and Bree and Hunter. So then also we did get a feedback from the building, so which is perfect. Now at least we have a visual, and thank you for sharing that. We have a visual when we're planning to it, at least we can say, okay, this is how the room looks like. So we can be a little bit more objective when we are scheduling those things. We do need, he's gonna send me the name of the vendor, so it'll be perfect. And then we need to discuss logistic of the people who are coming to the training, and of course, logistic for the volunteers also who are there. So there's more discussion, and we need to talk to the people who make those decisions and see how they can help us to make sure that day, or that week, sorry, especially the first week is successful for teaching all those 400 people. And then if possible, the second week or so, when we're going to different hospitals to see how and talk to the nurses and doctors for what is happening. So that would be great. I think there's one thing I forgot. When we were talking about the Muhimbili, the nurses and doctors, I know on your list you didn't have their anesthesiologist department people. Are they going to be part of the training or no?
Yeah, I think that we have to discuss with Dr. Mulungu,
Okay.
because he's he's head of department, so
Okay.
that's to be much better because he's the one who's controlling them.
Okay, because I know he was willing to, and he wanted those trainings. So I'm gonna probably touch base with him and see how many they are. And of course, definitely I'm gonna share this video so he knows that I'll be talking to him soon. He was there in the training yesterday, so I know he usually attend a lot of training. So we thank him for that. So at least we need to know, because we know if you're their section, part of the babies, they have to intubate, or they're receiving the baby who is requiring advanced airways, they need to be able to come to the training also, just to hear what we do or say and participate and ask for their section. Because if we know if they need intubation, our facilitators have been trained to do intubation. They can do specifically for the anesthesia group to make sure they get that training. Because for here, when they do neonatal resuscitation, including medication, intubation, and all the stuff. So they are equipped to do that. So if anesthesia there need that training, we can make those accommodation. Can be probably the second week we go back one day, send a few volunteers who can teach intubation and work with them. So that will be helpful for them. And we're going to do probably the same thing for the Buguruni and Mwananyama if the anesthesia needs some training for those things. But anyway, I mean, that's what I have, and thank you guys for coming. We're going to share this video so with other people and see the feedback. If there's anything come up and the question, please ask, and so we can improve this process and make it better.
Oh, I was just going to add too. So if we're talking about like the stakeholders getting together, if that happens, we could throw in a quick safety brief or something like that, or work the safety feedback, and then we can get that out of the way as well. And then I was going to tell Jafari that it was an excellent case study that he presented yesterday. So in Spanish, we would have called that patient Dolores. I'm not sure if Maricela, but that means like pain. It's a common name. It's Dolores. It means pain, because that lady sounded like she had some issues.
Thank you for reminding me. Yeah, so a lot of people are really excited about those case studies. They're like, oh, what about this? And I'm like, okay, you need to ask Jafari, not me. So no, it was helpful. Thank you. It's easier when you hear the content and then you see actually things happen. Yeah. It makes sense. And then, so of course, as I said, the second session is going to be even more interesting, because it's going to be, I mean, there's no much of the backgrounds that we just want to dig in for those patients one at a time, discussing each hospital, what can you do with this patient? But that's the only way we can learn. If that patient shows up in Muhimbili or Buguruni or Mwananyama, what kind of care are they going to get? And what care they should have? Yeah. So we need to discuss and dig down case number 3 and 4. And I think they were very interesting when I was reading them. Like, okay, I'm going to save the best for us. So we're going to see that. So we're going to definitely make you be able to present those cases before one at a time, and then the hospital needs to be able to contribute. So thank you very much, and I appreciate that support. Yeah.
Asante sana, Daktari Gabone. Asante sana, Timu QHSC. Asante sana, Lady V. Asante sana, Kaka Jafari.
Thank you, everybody. Strong work. So let's keep pushing along so we can get this done. Yes. So thank you for coming.
Thank you.
Thank you. Thank you, everyone.
Bye-bye.
Yes. Oh, wow.